Welcome to TCNtalks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Comeaux.
Hello and welcome to TCN Talks. This is always my favorite time of the month when Cordt Kassner and I get together and talk about the top news stories of the month. So this is for the month of April. How are you, Cordt?
Doing great, Chris. Thanks for having me back.
Yeah, man. Did you want to start with maybe a question this month?
Sure. I was taking a look and a question that came up. If you could pick up a new skill in an instant, what would it be and why?
I love that. I've always had a dream of playing the piano. And then, of course, I've been doing a couple of weeks of pretty tough travel. And I rewatched Maverick, Top Gun, and just watching them at the beginning of the movie, man, jamming on that piano. I've always wanted to play the piano, but maybe a more practical skill set is almost computer programming. And so I just think going forward into the future, like, for instance, be able to program a bot. That's actually a skill that I feel like we're going to have to be able to build your own bot. And I don't mean like a robot. I mean a bot, like go check my email and craft an actual draft or something along those lines. And so that's actually something I'm actively working on. It's funny, on the piano side, I had broke my femur in an accident many moons ago. And I thought, I'm kind of laid up. I did two things. I studied for my CPA exam and I took a piano lesson 3 days a week. And I made a little progress, but I've never had the time to do it again in my life after that. So how about you? How would you answer that question?
I actually go with the piano. We're similar in that. I played a little bit as a little kid and never had the discipline, the time to become good at it. And I think it would be fun to entertain other people with it. I think it'd be fun just to enjoy playing. So maybe that's a retirement bucket list for me.
And you're a little bit of a right brain, left brain guy, just a little bit. I've gotten to know you. And so you're probably a little bit more inclined to it. I've always wanted to do it because I thought it would stretch me to become more of a right brain person.
I always try to balance the artistic against kind of the quantitative, the math side. And there's so many advantages to both. Actually, Dr. Joy Berger and I, the editor of Hospice and Palliative Care today, she has her doctorate in music and is a concert pianist and organist. And we often have those right brain, left brain conversations because that was her first career, was in music.
I did not know that. I knew she was special, but now that just explains a whole bunch. Another reason why she's so special.
Oh, she's amazing at that. And maybe that's why it's top of mind for me. Like, I can do the math, I can do the computer programming to a degree, but music, like, I haven't taken the time to figure it out.
All right, man. Well, let's jump into the data. So what does the data show this month for Hospice and Palliative Care today?
Analyzing the click-through rates for Hospice and Palliative Care, today's April news stories. We published 379 articles that collectively received 157,000 clicks or reads. Notably, 37 of those stories surpassed 1,000 clicks each. All of these metrics surpass previous months, so we're growing in that readership and interest and click-through rates, which we're real excited about. Interestingly, the most clicked on story in April was Head and Shoulders, the most clicked on story, Head and Shoulders above any other story we've ever ran.
Wow.
And that was around medical aid and dying annual reports. The background of this was I saw a news clip that the Oregon Health Authority released their 2024 Oregon Death with Dignity Act data summary report. So this is like their 26th, 27th annual report. They release them every spring. It triggered in my mind that Colorado, where I am, also the Colorado Department of Public Health and Environment releases their annual reports every spring. So I launched from the Oregon report and went looking across all of the states where MAID is legal to provide an updated statistical reports for each state. So there's 10 states plus DC where medical aid and dying is legal. And Oregon is the only state that has their 2024 report data out. So it was also kind of a poke to the other departments of health that put out these reports that it's time. So to date, our most read stories have had around 4,000 clicks, maybe 4,200 clicks. But this MAID compilation had over 14,000 clicks on it, which was stunning to me. Our second most read story, or a category of stories, surrounded the Pope's death, Passover and Easter, and belief in the afterlife. This group of stories, focusing on spiritual and religious themes, had about 3,000 clicks each. And perhaps that makes sense in context of the holidays of April. On a side note, Joy, our editor in chief, and I had an interesting conversation around covering the Pope's death. This is, maybe a little peek behind the curtain as we talk about how do we run a story and what stories do we run and how do we put that information out there. It became interesting because we'd done a lot of coverage of Jimmy Carter, who not only is a former president and influential person, he had an extended hospice experience. The Pope really didn't have hospice palliative care, as we would kind of term it, and yet a very influential person. So it gave us pause to discuss how we cover that.
Yeah, I totally get that, Cordt, because I saw when you guys actually did it, and I was actually traveling that day, and I happened to look up, and I'm like, did the Pope die? I saw it all over the TVs in the airport, and I did see you guys release that, and I think something that's that big and national, it totally made sense to me that you guys actually did do that. The other interesting thing that just occurred to me in this category about belief in the afterlife, to this day, our most viral podcast we put out was with John Burke on Imagine Heaven. And so I do believe, especially in this work that we do in hospice and palliative care, that there is a lot of interest regarding that. So that didn't surprise me that was a pretty high category for you this month.
It's interesting to consider. I think it provokes more conversation around spiritual care, spiritual issues. Even from a Medicare perspective, where we collect information, hospices report information on discipline visits for doctors and NPs and nurses and aides, but not chaplains. And maybe there's something in these experiences that we can use to nudge CMS around collecting spiritual care visits and the importance of spiritual care in hospice that might differentiate from other healthcare fields.
Yeah, I mean, to me, it's what made us so fascinating from the get-go is that it was the first model of healthcare design around the belief, and also maybe today you could also call it the belief and the understanding that people are body, mind, spirit, social, emotional component, that we're not human doings, we're human beings. So we're kind of these spiritual beings having kind of a human experience. And so having a model, especially at the end of your life, where that is woven in, of course, always according to whether the patient or family wants that support, has always made us different. And it's interesting, one of the most profound hospice mission moment stories I could think of where the caregiver or the surviving family have come up to me, and the aspect of the pain, symptom management, all of that, they expected from us. But the transformative aspect was what happened spiritually and relationally with the family. And so, again, those are probably the most impactful for me as well, in terms of, oh, that's why we do this work. And the complete package is all important, pain, symptom management, all of that. But the thing that seems to transcend is those things on the relational and spiritual side. All right, what else you got?
Our third group of categories was really kind of our grouping, Joy and my categories around executive personnel changes, social media watch, and today's encouragement. So these are things that we've kind of developed along the way. About a year ago, Joy began compiling executive personnel changes to highlight leadership changes in our field that typically are not CEOs, because a CEO change is typically a standalone news story. But when we were looking at COOs and CMOs and other positions, it's kind of a way to keep track of where some of the people who've been longtime leaders in the field have landed. And so that has become a very popular category. We introduced the social media watch category about a month ago to spotlight information found on LinkedIn and other social media sites. really nobody else that I'm
Mhm.
aware of has been following or reporting on LinkedIn postings, which open up a whole new category. It's not peer-reviewed journal articles. It's not a reviewed newspaper story. So we try to be careful in it, but interesting that readers have really aligned with those.
Thank you to our TCNtalks sponsor, Dragonfly Health. Dragonfly Health is also the title sponsor for Leadership Immersion courses. Dragonfly Health is a leading care-at-home data, technology, and service platform. With a 20-year history, Dragonfly Health uses advanced technology and robust analytics to manage durable medical equipment and pharmaceutical services as part of a single efficient solution for caregivers, patients, and their families. The company serves millions of patients annually across all 50 states. Thank you, Dragonfly Health, for all the great work that you do.
And our Sunday newsletters highlight the most read stories of the week. So just recently, we began running what was the top story a year ago that
Mm.
week. And so, quite honestly, the first couple of times we've tried this, there's been very little traction, very few clicks on it. But I think it's more of a pondering, a reflection. Like, has anything changed? What has changed in the last year? So we're going to keep doing this for a little while and seek some feedback on that.
Just personal feedback, kudos on both of those. I thought the social media post was brilliant because you're right, you don't see it anywhere else. And then it makes me wonder, did I already catch that on LinkedIn? And I thought that was actually brilliant. I think you're probably right about the click-through, Court, because I for me, it's more of a brain kind of bookmark of, oh my gosh, that was a year ago, as opposed to necessarily going back to the article, but just thinking about, hey, a year has passed, what has kind of transpired related to this issue? So I think it's a great service. So you guys keep it up.
You've always been a fan of the history and trending over time. So I'm curious if our other readers are going to find that as equally intriguing. And then general themes, even thinking about what stories maybe that I thought would have high click-throughs that didn't. Really just, kind of our general themes around regulatory stories around the proposed hospice rule, stories about Volunteer Week and National Healthcare Decisions Day, veteran stories, clinical issues, research articles. We had a couple of stories about VITAS expansions in Texas and Florida. Um, all of those had around 1,000 clicks each. So it rounded out to be a pretty interesting month that overall had our highest click throughs ever. What about you, Chris? What were your insights as you take a look at the April news?
Yep. And just maybe one final comment in yours, just to remind our listeners that if hopefully you always listen to this podcast with Cord and I, if you're ever pressed for time, we actually publish his summary so you could see that actual data and statistics. And then, of course, what I'm going to cover in just a second, top news stories from the C-suite perspective. We publish this document as well. So it's a very quick way, good summary. If you're like, whenever they mention that, I'd like to go back to something. So here's my categories are always pretty consistent. And so mission moments, this first category, we had about 7% articles. 7% of the articles, by the way, there are 75 that I flagged this month, Cord. And so reimbursement, workforce challenges, and highlighted articles of interest is kind of my category, were the top 3 this month. So reimbursement had 17%. Competition to be aware of actually only had 1%. Workforce challenges had 21%. Patient, family, future customer demographics and trends, that was 11%. Regulatory and political, 7%. Technology and innovation, 7%. Speed of change, resiliency, and reculture, 5%. The human factor, 3%. And then highlighted articles of interest, you could call it Chris's category, 21%. So let's go through them. I'll highlight just a few in some of the categories. Like the first one, mission moments, there were 5 total articles out of that percentage and only one that I wanted to point out. All 5 were pretty cool. Always like doing the mission moment articles because I think about our good friend Mark Cohen when we used to do this, and he would always kind of bemoan the fact that you get less and less of those articles. And had that been a tool in newspapers of how we've kind of impressed people maybe impressed is not the right word, educated people about hospice and palliative care. And so when you see less and less of those, I like pointing them out. So the one that I pointed out or want to bring to our attention is kind of cool. It was from Fandom Wire, but it was about the 4th episode of The Pit. And so kind of the executive summary, it's a homage. Noah Weil quietly sneaked in a tribute in one of the best episodes of The Pit. And so his character, Robbie, monitored a patient during his final hours while dealing with his own thoughts about the death of his beloved mentor, Dr. Adamson. And he remembers the advice he received from him and shared it with the children of the dying patient as they waited for their father to pass. The phrase is, I love you, thank you, I forgive me, and please forgive me. So, Cordt, that's the tip of the hat to our good friend, Dr. Byock. It's actually my favorite book of his. And so that they wove that into The Pit. And it's actually my son and his fiance introduced me to The Pit, and I had not actually seen that episode. So that was too cool to see that was highlighted this month.
That's so cool. And I agree with you. The work that Ira has done and half a dozen books and uncountable numbers of articles, these 4 points are the number one things that I hear people talking about informally, if they credit him or not. And in my own experience, I mentioned last month, my mother passing away recently, that as I was sitting at her bedside, I kind of sat there and I thought, what bases do I need to cover? I love you. Thank you. I forgive you. Please forgive me. I thought, wow, thanks, Ira. And I hear those 4 points over and over. So it was really cool to see this picked up on the show.
Yeah, I agree. And a number of times I have mentioned that to other people who maybe weren't getting hospice, or maybe they even were in hospice, and just like knowing it was getting close. Gosh, I've probably done that 50 times. I've recommended that to other people. All right, next category, reimbursement challenges, warning signs, and implications. So there are 13 articles. I'm just going to read the titles of them because they were really good. But it also shows you we live at a fascinating time, Cordt, with what's going on in D.C. So here we go. Kennedy slashing 10,000 jobs and health department overhaul. White House cuts $12 billion in health funds. 5 updates. Medicare Advantage contractors, MACs, do not consistently meet Medicare cost report oversight requirements. Widespread firings start at federal health agencies, including many in leadership. HHS restructures duals, PACE offices amid department overhaul. How ACOs think CMS should change the rules for value-based care. CMS halts spending for non-medical in-home Medicaid services, likely affecting providers. Regulatory leaked HHS budget signals $40 billion in cuts and assumes ACA subsidies will expire. Ohio payer beats United Healthcare in racketeering lawsuit, awarded $50 million. Evaluation of the Medicare Advantage value-based insurance design model test from 2020 to 2023. And Medicare Advantage and Part D rate announcement. DOJ's lawsuit against Amedisys, United Healthcare set for mediation. Evaluation of Medicare Advantage value-based insurance model, key takeaways from the VBID. And I think that's it for that category. So I just wanted to cite those. There weren't a lot of click-throughs on those, and I felt like every one of those was pretty meaty, and C-suite leaders need to be aware of those. All right, next category. Next category, competition to be aware of. I only have one article, and I'm not even going to call it out in that category. Next was workforce challenges, and 16 articles. I'm just going to read the title. Kudos to you and Joy, because there were some really good ones this month in that category. And everywhere I go, I just come off MPHI's national conference, another national conference I was a part of. That was more leadership focused, but workforce is like on the top of so many different industries, kind of top concerns. So here's the titles. The cost of nurse turnover in 24 numbers. That was a great article. 2 key trends shaping the hospice workforce in 2025. Hospice care aids largest occupation in the U.S. as of last May. Health systems spend millions to reduce workplace violence. Federal court strikes down minimum staffing rule, the details you might not know behind the actual decision. 40% of nurses exit by 2029. Healthcare employee turnover by role. And here's on the solution side, managing oncology nurse burnout through peer support and emotional intelligence. The evolution of work, how Gen Z is reshaping leadership and workplace culture. That was a really good article. Build sustainable schedules to support physician well-being. What role do immigrants play in the direct long-term care workforce? And the future of management is hybrid, leading human AI teams in a new era of work. That was a pretty fascinating article. How physician CEOs are re-energizing later career clinicians. What leadership training is the next big thing in the RN to BSN programs? That was actually Nevada State University. Gave our good friend Nathan Adelson a heads up on that one. What's driving health system investment in Gen Z leadership? And then the last one, By the Bay forges educational partnerships to grow hospice and home-based care workforce. So 16 of those, again, just want to call out the titles. They were really great. Not a lot of click-throughs on those. Next category, it always tends to be a big one. There's just 2 I'm going to highlight, but there are 8 in my summary. Under patient, family, future demographics, and trends, there were 2 here. What happens when someone passes at home? It depends. And this was actually in the Bozeman Daily Chronicle. And another one here.
I thought it was a really interesting story as well out of Bozeman.
Yep, really was. So next one is housing instability complicates end-of-life care for aging unhoused populations. This was in the conversation out of University of Denver. I'm bumping into this more and more. There's one of the interesting kind of subplots of the silver tsunami is the housing insecurity for the baby boomers that are aging. They're also the first generation that didn't have defined pension plans. So they're kind of the first of the 401k kind of generation, if you will. Huh. So they're not all as well off as you would think. And so there's a lot of housing insecurity. So that's going to play out more and more in our healthcare world as we go forward into the future. All right, so next category, regulatory and political. There are 5 articles that I kind of put in the summary. There's only one I was going to call out. Hopefully by now all of our listeners know this, but the proposed FY26 Hospice Wage Index and Payment Rate was released. And so, in fact, we may even have an upcoming podcast with Judy Lemperson and Annette Kaiser where we're going to talk about that. Next category is technology and innovations. There were 5 articles in my summary, only 2 I was going to call out. Healthcare data breaches average 11 million per incident. And this was a report out of Becker's. I actually spent some time with a chief technology officer of a healthcare company, Cord, back in March. And what he told me scared the heck out of me related to cybersecurity. I mean, what's happening day to day in the cybersecurity realm? We have to be super diligent in this area. Other one that I want to call out under technology, inside Amazon's strategy to partner with digital health companies. This was a Modern Healthcare article that also kind of tweaked me. Court, have you seen the One Medical Amazon commercials yet? Man, those are fascinating, aren't they? It just looks so convenient. I've not tried it yet. Have you tried actually booking an appointment that way, or would you ever? Do you think?
Our family health insurance actually includes a concierge medical component that sold to One Medical. And so we use that now. And I would say the transition has actually been pretty smooth. How quickly we can get appointments and telehealth appointments and annual physicals and that sort of thing has been remarkably smooth. And it creates an interesting question in terms of what Amazon's trying to accomplish by moving into the healthcare sector.
Yeah, I wondered about that too. I mean, obviously the convenience of that, but then also the convenience of your pharmaceuticals via an Amazon type interactive function. Those 2 things make sense to me, but I like kind of how you leave that question hanging. What else are they kind of thinking into the future? It's going to be really interesting to watch.
Absolutely.
All right, next category, speed of change, resiliency, and reculture. They have 4 articles. I only want to kind of point out one, so 4 in the summary. Being a high performer CEO is not enough. True leadership involves empathy. This was in Fast Company. This moment calls for executives who can balance strong analytical skills with emotional intelligence. The CEO's role is evolving. Private equity is playing an increasingly influential role in shaping the expectations, performance, and the tenure of CEOs. The financial environment is also changing, with influence increasingly moving from public markets to private capital. In this landscape, CEOs are increasingly being measured by their ability to generate financial returns. But capital B-U-T. True leadership requires hitting more than financial targets. The most effective leaders understand that long-term success depends upon balancing financial acumen with empathetic leadership. Those who fail to adapt risk becoming transactional managers rather than transformational leaders, and understanding the shift in defining one's leadership approach is more critical now than ever. So kudos for pointing that one out. I thought that was an awesome article.
Uh-huh.
All right, last two. So the human factor, they only had two in this category. Only one I wanted to point out. One red flag that reveals bad leadership fast. One clear sign can tell you a lot about whether someone is leading well or failing miserably. Bad leadership isn't always obnoxious, toxic, or obvious. Sometimes it shows up in small, everyday moments, how someone talks to their team, how they handle mistakes, and how they treat people when no one's watching. So that was a great article. All right, last category, which is the Chris category. I had 13 of which I'm going to point out because all of them are just so fascinating. Again, none of them really had high click-through rates. First one, Bill Gates' AI jobs, 3 roles that will survive. Despite the potential for widespread automation, Gates identifies 3 key areas where human expertise will remain indispensable. Number 1, creative work. Those that require high levels of emotional intelligence. Guess what the superpower of the future is going to be? We've got a podcast coming out with Daniel Pinckford that talk about his book, A Whole New Mind, which is really what he wrote about in that whole book about the left brain skills are not the future. And then the last one, which kudos to my third son, who's actually in HVAC, skilled trades. That's the one that AI is not coming for. So I thought that was a great article because I don't know about you, but I see a lot of consternation about, well, what is this going to mean for like jobs? We even had an interesting discussion amongst our own team. And I keep kind of reiterating, perform your job in such a way that a robot never could replace you and never will, which is really poking on kind of that level of mastery. All right, so next article. Are hospitalists becoming de facto PCPs, primary care physicians, for patients with complex illness? Hospitalists are becoming primary physicians for patients in decline. Hospitals are the new clinic for patients with complex illness. And hospitalists are increasingly initiating discussions about patients' values and their goals. Sounds like kind of them adapting some superpowers that we see in our palliative care teams. So I thought that was a great article. Next one, seeking human empathy, health insurers turn to AI. Let me read that again. You're laughing too. Seeking human empathy, the health insurers turn to AI. It's a modern healthcare article, and I'm just going to let the title speak for itself because I even had to read it a couple of times. And I see your editor's note. Is this backwards? What happened to human kindness? Courtesy and core of respect. Yeah. All right, so next one, senior living demand hits an all-time high. This was in McKnight's, and I think the trend line on that is supposed to be more and more and more. I have a good friend that's predicted that the healthcare solar system will no longer revolve around healthcare systems. It will actually revolve around senior living communities. Not that there's not a place for hospice and palliative care. There is. It's just like, who has the biggest balance sheets, the biggest resources available, et cetera. All right. This was interesting. New York legislature passes bill banning new for-profit hospices. So kudos to our good friends in New York State for getting that passed. Thought that was kind of a big one.
Passed through the legislature. I was talking with Jean, and it's going to the desk of the governor, and so we're going to see if that gets signed into law or not. But it did pass the legislature.
Yeah, well said. Thank you. New Mexico passes the nation's first legislature-driven psilocybin access act. Of course, we dropped the podcast last week of Dr. Rohini Kanagante talking about the use of ketamine and other psilocybins in the hospice and palliative care space. Even my son actually circled back and said, that was an awesome podcast. So check it out if you haven't listened to it. Next one, Dr. Oz outlines his vision for CMS, 8 keynotes. This was actually in Becker. I'll just hit like 5 of them. As a first step, CMS will implement President Trump's executive order from February aimed at boosting healthcare price transparency. Number 2, CMS will work to streamline access to life-saving treatments by equipping providers with better patient information versus unnecessary paperwork. Number 3, identifying and eliminating fraud, waste, and abuse is a top priority for the agency. Number 4, CMS will focus on prevention, wellness, hey guys, shout out for us, chronic disease management. And then Dr. Oz promoted the use of artificial intelligence avatars during his first all-staff CMS meeting. So those are just top 5. There are 3 more, but those are the most important ones I wanted to point out. Next, closing the gap in end-of-life care coverage, the role of nonprofits and policy advocacy. Kudos to James Desmond at Hospice of the Low Country. He did an awesome article for Forbes and just talked about as end-of-life grows, so will the gap between care that patients need and what they receive. Then he talks about a lot of the challenges that people see, workforce shortages, restrictive regulations, outdated reimbursement models, misconceptions around hospice services, or keeping millions of Americans from accessing quality hospice and palliative care. Those barriers disproportionately affect low-income families, rural communities, and communities of color. Unlike for-profit entities, nonprofits are able to prioritize community needs over shareholders' returns, what shareholders are looking for in profits. We could prioritize patient well-being over profits, and to say it more directly, we put people over profits. And I've seen firsthand how advocacy can drive progress. And then he talks about the things that nonprofits must engage in, raising awareness and education, lobbying and legislative engagement, and of course, expanding access. So kudos to James. That was an awesome article and awesome that Forbes picked it up. Next, pace growth expected to continue amid HHS reorganization and provider uncertainty. So a couple of red flags or just maybe concerns that'll be interesting to see. Next, Avena CEO, Medicaid uncertainty is detrimental to the market. So the Avena CEO just kind of bemoaning kind of the uncertainty of what's going on in Medicaid and how that's affecting some of the markets and the share prices around some of the publicly traded hospice, home health companies, etc. Next, quality of nonprofit hospice affiliated with integrated healthcare systems. Research shows that hospice primary caregivers report better quality of care at nonprofit than for-profit hospices. But there's variation in quality across nonprofit hospices. CAP hospice scores did not differ for a hospice as part of an integrated healthcare system. I'm not surprised by that, Cord. I'm sure you probably want to comment on this too, but some people think that joining a healthcare system is like is a safe harbor. When the reality is hospitals are going through major changes and challenges to their own reimbursement model. They're having to go through a huge metamorphosis. And so it's not like they got a lot of capital lying around to go, yeah, we don't really understand your business, so we're going to put all these resources. In fact, what happens is hospices that are part of hospitals is you're a sub department and you don't get the resources. And so we've actually done a couple of consulting projects where we've actually helped hospital hospices, and you just see that they don't have the resources, they don't have the focus, and it's really hard for them to get it. In fact, the healthcare system, if there's any margin, the healthcare system sucks the capital out and puts into, because they've got their own challenges, like we got to build a new ER or a new bunch of beds, etc.
Yeah, and I would just tack onto that maybe a slightly different angle. Whenever I see Joan Tino's name on an article, like I stop and I read it twice because I respect so much what Dr. Tino does, the work she does, her perspectives, the broad array of topics that she examines, and I think there has been a lot of research of late around the for-profit sector in hospice and looking at private equity and publicly traded versus independent freestanding for-profit hospices. What does that look like? Why is it changing? This was one of those few articles that I've seen that kind of parses apart different sectors within nonprofit hospice and is looking for comparisons and which sectors of nonprofit hospice provide highest quality of care and sustainability and some of those issues. So I thought it was really pretty interesting that Dr. Tino took this on. And, as you said, sometimes there are not differences. And that's interesting too. Like everything that's important does not have to be statistically significant. When there's no difference, sometimes that's pretty interesting too.
Well said. Really well said. It's something you also made me think about that just is kind of tangentially related. But you know that there's the huge movement, and Mark Cohen was the first to predict about hospitals, their nonprofit status being challenged. That's going to be an interesting one. I was trying to see if I'm almost positive it was in one of our predictions that was going to kind of ratchet up this year. I think it was actually one of Mark's predictions, and that's actually occurring with a vengeance right now. So that's going to be really interesting to see. I mean, you kind of go, well, they're only called a nonprofit because they're under this kind of broader umbrella of the nonprofit of the hospital. But yet, kind of what a lot of, like Senator Grassley has been a key one, kind of pushing in and say, you don't really look like a nonprofit. But that'll be interesting how that plays out as well. 2 last articles. Belief in an afterlife is increasing in the United States, even among the non-religious. And so kudos for citing that one. You and I kind of talked about that earlier. Again, our top podcast was Imagine Heaven with John Burke. And then just the last one. This is so interesting and timely. Special report, examining group health coverage alternatives for small employers. And so, Cordt, as we look for what rocks can you pick up and find some cost savings, we actually have a visionary council meeting that only our TCN members are a part of that's coming up in May. And we're actually going to bring one of the top firms in the country and talk about some interesting, innovative ways. There are some really cool things that are happening that there's just so many more flavor of menus of things you can do now to save money. You don't have to go fully self-insured. There's some interesting kind of hybrid products, etc. So maybe you and I can talk about that a little bit further. But again, this one wasn't clicked on very much. And I know a lot of my C-suite peers out in the country were like, man, 2% rate increase, that's not going to cover the inflationary things that we're dealing with. So then where are the cost savings? There may be some stuff in your benefits that you didn't even know were sitting there, some possibilities, some innovations where you could maybe even increase some services and save costs. I mean, where's there any win-win these days? There are not many of them.
Yeah, absolutely.
All right, Cordt. So again, there were 75 in total. Those are just the ones that I wanted to point out this month.
You covered a lot of ground with that. I'd love to follow up with you for a second around one question that kind of ties into our predictions for 2025. We had talked about workforce challenges, and I noticed that you had the most articles in the workforce challenges area this month. We've gotten through first quarter of 2025. As we look ahead through the rest of 2025, from a leadership perspective, what are your thoughts related to workforce challenges? How can hospices better position themselves to maximize impact the remainder of this year?
I love this question. So, whenever COVID hit, we had obviously just the oh crap moment because just it hit so acutely with staffing. So one of the things that we do with our members is we institute something called LDIs, Leadership Development Institutes, where on some frequency they bring their leaders together and do some leadership training. So given the acuity of it during that kind of first year of 2020, we had actually dedicated about half of probably 3, maybe 4 LDIs of certain members where we did some brainstorming with the leaders of our member and some TCN team members. And, Cordt, I'm an accountant. And so I started to see some categories of like the ideas that they were actually throwing out. And we actually started to create kind of a plan of kind of gathering those ideas. In fact, we called it OS1. I can't say on air, but it was O with the S word, 1, because of just how acute the issue was. And actually, we're pretty close. It's going to be first available to our members, but it's basically calling this workforce solution comprehensive toolkit, basically. And I'll just kind of cite some of the categories that came out of, like, these are some things that you can work on. I know we live in silver bullet, quick fix, drive-through. These are not quick fix kind of drive-through type things. They're broad categories that you need to work on over the course of time, because here's the reality. This is not going to get any easier. It's going to get even more difficult as the silver tsunami of the baby boomers crashes on shore. So what can you do? And we actually have a category of technology and innovations, because I do think we're going to see robots in healthcare. There's no question about it as we get beyond our first segment of artificial intelligence to agentic AI, or some people call it AGI. And then you're going to get to super AI. And at super AI is when the robotics and the AI is going to come together, and you're going to have a thing that can actually reason, maybe could even project empathy, etc. And we know that sometimes Japan is a little bit further ahead with technology. They have actually deployed robots in actually some hard to staff situations. So you already got kind of an experiment running in other parts of the globe today. But here are the categories. So clinical documentation, communication, culture, diversity, equity, inclusion, and belonging, reward, recognition, engagement and support, innovations and technology, learning and development, protocols and compliance, because some of our protocols and compliance create friction with staff. So if you could actually lessen some of that friction, then you can help with staffing issues. Talent acquisition, salary and benefits, and work environment and schedules. So each of those categories have a whole bunch of solutions that you could deploy to work on the workforce issue. Also, Cord, one of the things so this is one of our top challenges we identified. There are 8 in total. We did about 7 to 8 years of research, came to the conclusion there are 8 challenges. Workforce is a huge one. In fact, Jean Shakiro and I kind of did a podcast together with kind of her categories, and there was a lot of overlap between hers and mine, but workforce, again, was one of the biggest ones. So one of the things we deployed this year is future councils. So we're bringing our members together, even some of their board of directors, and I recruited some national experts in these categories, and we are wrestling with the challenge and what are some solutions that could be deployed. This is a good template of what I hope will come out of all those challenges. It just so happens this one was a work in progress already coming out of COVID in 2020, et cetera. So all that to say, we're actively working on this one. I wish it was, we found there was this one island where these healthcare workers are being cranked out. We've now got the immigration policy, so we have the corner in the market of that people factory. No, it's not going to be something like that. It's going to be working on these broad categories over the course of time. So I'm curious what thoughts you have.
I think you just gave the master class in that, and I know that's not what's queued up for today, but we might want to circle back with that in mind for a future master class, because it is brilliant. It is so multifactorial and challenging to address this. I tend to approach it from some of the data categories that I look at. If there are workforce shortages, how does that impact a hospice financially from having employees versus having to hire traveling workers, which cost a lot more? How does that impact your average daily census and the ability to bring more patients on if you don't have staff to actually serve them with the degree of quality that you're aiming for? How does that, if you have a lower ADC, how does that impact hospice utilization rates? And so to me, I'm trying to tie together some of the data components around the impact of workforce shortages. And workforce shortages was one of the key factors of 2024. We're already predicting and seeing how that's impacting 2025. And in Cord's perfect world, we're going to start pulling out of that being a major challenge in 2026. So kind of next year, as our country is evolving and changing, it's going to be fascinating. But I think we're getting there, and the topics that you covered on that are need to be unpacked. I mean, that was brilliant.
No, thank you. And actually, my prediction for 26 and beyond is it's not going to go away. And so it's maybe we just gotten cozy with it, but it's going to continue to be a challenge. And the things that you poked on, like using contract staff, that's just a Band-Aid. And so you've really got to work on this. I'll give you one small example that's kind of tucked in to one of those categories I mentioned. Can we graph in other disciplines like what about paramedicine, especially community paramedicine? Now, do the regs actually support that? And so quite often, right, the regs do not support or don't, sometimes even they're counter to innovation. What about community health workers? And so when you look at some of our peers internationally, that is a discipline graphed into more, so that way people could really practice at the top of their license. So yeah, you nailed it. It's probably a future discussion, future podcast, future master class, because there's a whole lot more to unpack. And we'll also have a whole lot more this year as that future council wrestles with this concept. So you mentioned master class. You're up this month. You want to take it away?
Yeah, thank you. We had talked about perhaps spending a couple of minutes better understanding the National Hospice Locator, which is a website that I created back in 2012, and the impact that it's having now. And there's some data pieces, some quality pieces that fall into this. So for those of you unfamiliar with the National Hospice Locator, it can be found at the URL www.nationalhospicelocator.com. It is near the top of Google results when searching Find Hospice or Hospice Near Me. It receives over 12,000 hits per month. And the purpose of the NHL is to direct the public to high quality hospices for their loved ones. And searches can be performed not only on quality, but also based on hospice name, zip code, city, county, or state. The first 50 hospices meeting search criteria are included in the results. And because this is such a popular web page and a little controversial, like what does it mean to rank hospices by quality? How does that work? That's what we want to talk about today. So really 2 points to highlight for listeners. First, this website includes information about every known hospice location in the country. Let's talk about that for a second. And second, default results are sorted on quality, and we're going to unpack that too. So first, this website includes information on every known hospice location in the country. I start with the Medicare current provider of service file, which lists all active hospices. And then based on my research, overlapping with state departments of health and other websites, I add in satellite offices, prison hospices, pediatric hospices, non-Medicare volunteer hospices, and more. Per last week's update, I'm aware of 7,780 hospice locations in the country.
Wow.
And this is just, it's challenging. Like you'd think, oh, we need a directory of hospices. How hard can it be? Well, it gets difficult. Just to pick friends in Grand Junction, Colorado, Hope West has one CMS provider ID and 4 locations. We could talk about Vitas in Florida. They have one provider ID in Miami and 50, 80 locations across the state of Florida. So if we're counting hospices, are we talking about the one or are we talking about the 80? And from a Medicare claims perspective, we're talking one because it's based on the billing address, if you will. When we're talking the National Hospice Locator, we're talking the 80. So the first step is actually creating that comprehensive directory of all known hospice locations. So name, address, phone number, website address, that sort of thing. And then I add more publicly available information, such as are they accredited? Average daily census, which comes out of hospice item set now, initial date of Medicare certification. Some of those fields are actually based on long-standing reports, how to choose a hospice. NHPCO had a list of 10 items, how to pick a hospice. And so those kinds of components have been integrated over time to help the public find hospices. The more controversial piece is really the second point, sorting hospices by quality. So in 2012, when I started this, I sought and was able to get some underwriting from 4 hospices across the country that also saw the value in this kind of a web page, and the default sort was based on average daily census, largest to smallest. The idea was the bigger the hospice, the greater the capacity to have a broad scope of services. Like, we don't know if big hospices do that, but it was a reasonable assumption that they would. And about 3 years ago, with input from hospice leaders around the country, I created a quality matrix and assigned a ranking score to every hospice. So how does that work? First, it's not one criteria point. It's not a star rating, of which only a third of hospices have a star rating. So I chose 7 criteria from different sources. Hospice visits in the last days of life from the hospice item set, staffing ratios, which is information pulled from the claims, levels of care, which is pulled from the claims, which is simply, does the hospice provide all 4 levels of care? And there's a way that we rank that. We look at the hospice caps in the question around definitely recommending this hospice. Stability is the fifth criteria. So 6+ years since initial Medicare certification or the latest change of ownership coming out of the provider of service files. Are they accredited coming out of the provider of service file? And a health equity measure, which is, do they provide any Medicaid pulled from cost reports? Then I calculate a score with the highest possible value being 100 points. So if each of these measures, if these 7 measures were all considered equal, each of the 7 measures would have a value of 14 points. But they're not considered equal. They're not all considered the same weight, the same value. Hospice visits in the last days of life has a potential of 30 points out of the 100. So almost a third. And that's really coming from feedback from CMS, from Kelly Von Tran, the CMS Deputy Director of Hospice, who has been quoted several times around hospices have to show up. You have to put a person in the room. And so this issue around hospice visits in the last days of life, our hospice is showing up. That's why that's weighted so highly. Staffing ratios, 20 points. So these first 2 measures account for half of the weighted value. That came from a conversation with Dr. Bayak around the importance of physicians and nursing and the other disciplines showing up in appropriate patient-staff ratios. Similar conversations and examples for each of these 7 measures. There's a couple of questions around this that often come up. How does a hospice update their information? Like if they change their address, change their brand, change their name, how do we update it on the NHL? There's a link at the top of the webpage. Fill out a form. It comes to me and I update it. So
That's
quick
great.
and easy. Do I need permission to do this? I recently had someone not so happy with their quality ranking and being on this website at all. But frankly, no. I don't need consent or permission because all of the information we're using is publicly available. I'm trying to present it in a helpful format, but I really don't need permission around this. This individual, about a month ago, threatened to report me and my work on the National Hospice Locator to CMS. And I just suggested she say hello to them for me because I've met with the hospice team and discussed this with them. So it's not to be argumentative. This is a tool intended to help the public find high quality hospice. How does a hospice improve its quality score? That's kind of the last frequently asked question. I'm happy to meet with any hospice leader and review their quality score, where they're at. Sometimes when I get calls from hospice leaders, it starts off a little heated, like, who are you to judge my quality with a low quality score? And I start off very simply. I'm a nobody researcher in Colorado. Like, this isn't about me. So let's take a look at the formula. Let's take a look at your hospice visits in the last days of life score. Oh, I see it's a little bit low. It's like 45%. You know that, right? You know that's pretty low nationally, right? And that's about when the conversation tone changes. Well, yeah, we do know that's kind of low and we're working on it. Okay, well, if you want to improve the NHL quality ranking, let's start with improving your hospice visits in the last days of life score. So it quickly pivots. It's not about me. It's not about this website. It's about how to improve quality. And so let me end with kind of a story and a challenge. I mentioned last month, my mom had died. She was in the hospital, and prior to being admitted to hospice, the hospital social worker called me and said, your dad said you might have an opinion on which hospice we should contact for your mother. I was driving at the time, and I said, well, yeah, I do have an opinion about that. Could you please go to nationalhospicelocator.com and type in the city? She did. And I said, I want one of the first 3 hospices listed. And she said, what is this? And I said, well, it's a tool that ranks every hospice by quality. And there were 20 hospices in this city. I said, I want one of the first 3. Like, I believe in this. I'm so confident, not to say the method is perfect, but I trusted to the care that my own mother received.
Mm.
And there were some challenges around that. But like conceptually, this was a really important step and a challenge. Like I recognize publicly sorting hospices by quality can be controversial. However, at least somebody who's doing it, me, has 25 years of research experience working in hospice. At least somebody who's qualified is steering the ship. And when I go looking for health care, when I'm talking with family members and friends, I sure wish somebody with 25 years of research experience in prostate cancer could guide me to the highest quality urology oncologist, or the highest quality breast cancer doc, or the best COPD doc, or dementia doc, the best home health agency, the best nursing home, right? I mean, we could go on because when I go looking for the best of any of these, there's nothing out there.
Mm-hmm.
And that's frustrating. So at least we're trying to do something. And like I said, the intention is good. I'm highlighting the high quality. I'm not trying to spotlight or shame and embarrass poor quality. I just say, gosh, if the score is low, maybe we don't have information. Like that's not the purpose. I'm not trying to throw anybody in jail here. I'm trying to highlight the highest quality performers. And so the challenge that I offer is I work in data. And if I accept a challenge like this to try to improve access to high quality care, what's your corner of the world? How can you improve care? How can you improve patient quality in your corner of the world? So thank you for letting me take a minute to explain that. And I'm happy to talk with anybody more about that offline that's interested.
No, I totally appreciate you explaining that, Cord. And also thank you for the work that you do in this area. First off, my team had asked me because they had actually used your locator for something. And so I knew we were doing this master class. So I'm going to share it with all of them because they were asking me for the methodology. So now everyone has the methodology. Quite often I will quote and say, how many of you ordered something for Amazon this past week? And of course, everybody's hand always goes up in the presentation. How many of you looked at the reviews before you actually press the purchase button? We all do that, right? And we're all expecting that in every facet. And so healthcare is obviously a lot more difficult. And kudos to you because it is difficult. When I had Peter Benjamin on a year ago, and he's like, here we are, 40 years later, and we still don't know what defines quality. Well, do we not? We do. It's not perfect. I mean, that's the challenge is that what does a good death look like and what's the best measure? But there is measures. And so my hat's off to you that you're doing this. The number of times I get a call per month, hey, Chris, do you know someone in Topeka, Kansas, or do you know of someone in Phoenix, Arizona? Who would you recommend? And so pointing people to your website is more and more, number one, I usually do have a recommendation because I usually know people in the market. And number two, you also can go and look for yourself. So again, hats off to you. Thank you for the work that you're doing in this area. And now people have feedback. I know you're willing to receive that feedback.
Always. And that's always the big question is, how would you do it differently? How can I do this better? Do we need different measures? Do we need more measures? Do we need to weight them differently? Like, I can change the methodology and upload it nationally. It takes about a day. Like, This is not something that needs, lots of consultation and takes 3 years to change the methodology. This can happen quickly. And that's really the point of it.
Yeah, I have a feeling someone's going to take you up on that too. Might be one of the team members, which is great.
I hope so.
And I think it'll be a good debate and a good discussion. So, all right. Well, Cordt, thank you. To our listeners, we always appreciate you. Thank you. Cordt and I do this. First off, the work that he and Joy do at Hospice and Palliative Care today is a great service. How they scour all these different resources and give you a daily tool of here's what you shouldn't have missed. And then us making sure once a month we're like, hey guys, here's what the data showed and here's what my perspective is as a C-suite leader. And so again, we do this in service to you. You have a tough enough job as it is being a hospice and palliative care leader, but staying abreast of what's coming is absolutely necessary, especially these next 5 years. I think they're going to be pretty fascinating. So be sure to hit the subscribe button. Pay it forward to your friends, your family, especially your coworkers, your fellow workers, etc. And as always, we always like to leave you with a quote, always to make you think more. This actually came from Hospice and Palliative Care today on April the 8th. The scars you share become lighthouses for other people who are headed for the same rocks that you hit. That's by John Acuff. Thanks for listening to TCN Talks.